All right, everybody. Good morning. Welcome. This is going to be a session about different roads to neurointervention within the VIR career. I am your host, along with my co-host, Arashleen.
Hi, thank you everyone for joining us here today. This will be our first installment of our Road to Neurointervention panel series. We're so glad to have you here today. And as Dr. V mentioned in the chat, thank you so much for our international viewership as well, IR Juniors, Unite UK, and everyone here in the US. And a special thank you to our panelists for joining us. So before we get started, just a little bit about WCVIS. The WCVIS is developing a trainee section to educate, recruit, and connect those passionate about pursuing a 100% endovascular and interventional surgical career with comprehensive and longitudinal clinical care. The direction of VIR as a specialty will be defined by those who will not compromise in providing the best possible care to their patients. And that is the mission that we try to promote amongst our trainee resident, medical student, pre-medical, and early career section.
And here are a couple ongoing projects that we have going on. There's a spreadsheet being created for all VIR programs. We have multiple series from How to Crush Your Sub-I to the Acute Care series, Match series, Unite, Landmark. So please check out our website to see all of the things we have going on. We're also creating educational resources such as guides for Spanish-speaking patients. We have mentorship opportunities, and we're also coming up with a podcast on 100% VAR practices and more as they come.
So for ways to get involved, if you are interested in joining the WCVS training section, you can scan the QR code to be able to join by Google form, and you can follow us at WCVIS Society on all socials. And these meetings are recorded as well as our other panels and events that we've had in the past. So to catch up on those, they're all uploaded to YouTube. And you can add our Google Calendar to your calendar to stay up to date on upcoming events. And wcvs.org is our website where we keep our sections up to date.
All right, and without further ado, I'm excited to introduce our panelists. I don't know if Dr. Chen has showed up yet, but she is an incredible physician. She's from Sugar Land, Texas. She originally attended Dartmouth College with a major in economics, and then after completing a master's of epidemiology at the University of Cambridge in the UK, she returned to Texas to attend University of Texas at Southwestern, where she served as co-class president. With an early interest in interventional neuroradiology, she completed diagnostic radiology at Mount Sinai West in New York and continued with 3 fellowships, one in diagnostic radiology at Johns Hopkins Hospital in Baltimore, and then going on to interventional neuroradiology at Mass General Brigham and pediatric neurointervention at Boston Children's Hospital. She is currently the director of pediatric neurointervention at Texas Children's Hospital and an assistant professor at Baylor College of Medicine with dual appointments in the Department of Radiology and Neurosurgery. Before joining Texas Children's, she was an instructor at Mass General Brigham in Boston, Massachusetts, in the Cerebral Vascular Division of the Department of Neurosurgery, as well as was affiliate staff with Boston Children's Hospital. She has interests in pediatric neurovascular diseases, fetal translational therapies, and high-flow vascular anomalies of the head and neck. Outside of the hospital, she enjoys running in Rice University and Herman Park with her golden retriever Sally, and she's true to her Houston roots. She loves to cook and explore Houston food with her incredibly supportive and loving husband, Pablo Valdez Cuevo, and 2 little ones, Sebastian and Jiel.
Next, I'd like to introduce Dr. Joanna Kee-Sampson, who we are fortunate to be joined by today. She is Associate Professor in the Department of Vascular and Interventional Radiology at Atrium Wake Forest Baptist Medical Center in North Carolina. She completed her radiology residency at Atlantic Health System in Morristown, New Jersey. She finished her vascular and interventional radiology fellowship at Brown University in 2017. She previously served as faculty and program director for the Vascular and Interventional Radiology residency at the University of Florida, Jacksonville. She joined Wake Forest Baptist Medical Center in 2025, and she serves on the board of directors for the Associate Program Directors for Interventional Radiology. She holds the position of Secretary and Treasurer for the Southeastern Angiographic Society, and her clinical interests include aortic and peripheral vascular disease, stroke, pain, and palliative care interventions, and vertebral augmentation. And we're very excited to hear about her experiences today.
And then we have Dr. Daryl Goldman. She is a dual-trained interventional radiologist and neuroendovascular surgeon. She is the first physician to complete CAST-approved training in neurointerventional surgery, and she is now part of the neuroendovascular group at Mount Sinai as a staff physician, where she takes care of patients with vascular disorders of the brain, spine, body, head, and neck. Her clinical and research interests center on arterial and venous thromboembolism, advanced endovascular stroke therapy, endovascular treatment of arterial aneurysms, and vascular malformations. She's also passionate about the emerging field of interventional neuro-oncology, which sits at the intersection of endovascular therapeutics and precision neuro-oncology. She has extensive training and experience in interventional oncology techniques, including Y90, radioembolization, chemoembolization, and targeted drug therapy. Dr. Goldman has authored over 50 peer-reviewed publications and book chapters and has presented at numerous national and international conferences. Her research has spanned a wide range of topics, including playing key roles in multi-center investigations on procedural predictors of neurological recovery after thrombectomy. A committed educator and leader in the interventional radiology and neurointerventional surgery communities, Dr. Goldman has served as course director for multiple national symposia and was a founding leader in initiatives to expand education opportunities within the field. She has held leadership positions in the Society of Neurointerventional Surgery, Society of Interventional Radiology, Radiological Society of North America, and Global Embolization Symposiums and Technologies. We are extremely lucky to have her here today.
Dr. Dhand might not be joining us today. He's on call, but would still like to introduce him. Dr. Dhand is an interventional radiologist at the Los Angeles Imaging and Interventional Consultants and currently at PAH Health in Los Angeles. He is the director of Western Angiographic and Interventional Society and a host on the podcast we all know and love, Backtable. He completed his undergraduate, medical school, and residency and fellowship trainings at Northwestern University, and also does a great deal of stroke work and neurointervention. So
All right, let's get into the questions. So, when and what sparked your interest in neurointervention?
Oh, I see. I've been spotlighted, so I should. Thank you. So I first actually became very interested in neurointervention during my medical school in, I think it was the end of third year. And I was on neurology rotation and had a patient who come in with a acute ischemic stroke, and I got the opportunity to follow them to their intervention, and was just blown away by how incredible the whole thing was. I was at Ochsner in New Orleans, and they have their neuroendovascular and body interventional suites all in the same place. And both their physicians do kind of crossover a little bit. So once I went down there for the stroke, then I was able to form relationships with the whole department and became very interested in interventional radiology as well at that point. But my first exposure to endovascular intervention was through this stroke. And after that, I fell in love with body IR and didn't really think that I was going to do neuro IR for sure later on, but always really, really found it fascinating and wasn't sure if I would do it in the end. And then during my residency, I sort of found my way back to neurointervention. And during my first year, actually, at Mount Sinai, um, again, the suites are in the same area as I think most places sort of are. And I started watching more neuro cases. And at that time, the neurosurgeon, the endovascular neurosurgeon at Mount Sinai was very interested in developing this new pathway for IR integrated residents to pursue neurointervention. And so I got really lucky and was it kind of at the right in the right place at the right time, um, and was able to go to join this pathway, which we can talk about, I think, probably a little bit later, right? Or do you want me to keep going?
I think we will touch upon that. We have a section that goes into the different pathways.
I guess I can also talk about, what first sparked my interest in neurointerventional. Um, so that was actually during my fellowship. I even though, like my fellowship was a body IR fellowship, Brown was very unique in that the neurointerventional was kind of seamlessly blended into our training. So there was not really a division in, well, first of all, it helped that, at that time when I was there, there was no um, neurosurgery that had like a neuroendovascular pathway, and there were no neuro IRs, so no neuro IR fellowships. So the body IR, so us, the IR fellows did body and neurointerventions seamlessly throughout the day. And so that was kind of my first exposure to neurointerventions. And from there, I really grew to love the pathology of stroke and helping stroke patients. And in addition to that, I also, developed just an interest in doing kind of head and neck vascular work, particularly trauma and like epistaxis, et cetera.
All right, thank you for that. And then what does the training pathway look like for a VIR physician who wants to incorporate neuro?
I think I think that there are a couple of right now, currently there are a couple of existing pathways, and also depends on what aspect of neuro we're talking about, right? So um, there are a lot of body IR trained people doing stroke. And primarily, in general, the people who do body IR, who do body IR trained, who do neuro, primarily just do stroke. And as far as I know, like it's less common that they would do any other neurointerventions like aneurysm coiling or pipeline or anything like that. Um, and then there are, the newer pathways, which I'll let Daryl kind of go into that a little bit because she just lived it pretty much. So.
Yeah, that's what I was hoping to get into next. So, beyond informal training, what are the formal fellowships or certifications that allow you to enter this space and do some of those other procedures that Dr. Kee-Sampson had mentioned?
So there are traditionally sort of three different specialties entering neuroendovascular. There are neurosurgeons who are typically trying to specialize in vascular neurosurgery, and they do endovascular training as well. And for neurosurgeons, so I'm going to I'll go into kind of us specifically at the end, but neurosurgeons, they have to do 2 years of endovascular, and they do one typically enfolded in their residency, one of their years, and then they have to do one formal fellowship year. in endovascular after their training. So total, it would be 8 years for them. They do a 7-year residency with 1 year enfolded and then 1 year fellowship. And then there's neurology. And neurology, they do a neurology residency followed by a stroke or neurointensive, I guess, so like a neuro ICU fellowship or a stroke neurology fellowship. And then after that, they do 2 years of neuroendovascular fellowship, and they have to do 2 years. And then there's radiology, and the traditional pathway for radiologists for diagnostic radiology. And some of the forefathers of neuroendovascular intervention are neuroradiologists, okay? And they did a diagnostic radiology residency, followed by a neuroradiology fellowship, followed by 2 years of neuroendovascular intervention. And so they did 2 years. But they had to do the neuroradiology fellowship also first. And then there's people that went into IR. So, Dr. Kee-Sampson, she sort of did, as she was saying, she was at a place that had really good access to neurointervention while she was doing her IR fellowship. And so some of those people that have done IR fellowship after radiology, this is before the IR integrated residency. They did radiology, then they did an IR body fellowship, and then they wanted to do neurointervention. And some of those people that I've met were lucky that they got to sort of get exposed to neurointervention and stroke during their IR training. And so they got credentialed in stroke, right? And then some of those people were stuck where they wanted to do neurointervention after their IR body training, and they were sort of forced or told that they had to go back, do a neuroradiology fellowship, and then do a neuroendovascular fellowship after that. Okay. Those people, typically, most places let them do 1 year of neuroendovascular because they had the body IR training before. But some places really made them do a full 1 year neuroradiology fellowship and then a 2 year neuroendovascular fellowship. And you can imagine that's a lot of training, right? And so most of the people that I know that are further along in their training, that's the pathway that they had to do. Then there are people that are the new pathway. And it's hard to tell you that it's really a new pathway because it is a new pathway, but it's really not very accessible or available anywhere right now. And it's sort of just on the cusp. So I want to sort of preface with that, and that I've been very lucky to train somewhere that has it and that started it really. So, and that is the pathway for IR integrated residents to get into neurointervention. And the way that we did that is to do it's 1 year of formal neuroendovascular fellowship after our 6-year IR integrated residency. However, there's a lot of prerequisites involved. So it wasn't just 1 year. I ended up doing close to 2 years of neurointervention throughout my residency. But the formal requirements are clinical rotations throughout the residency. So I had to do 2 months of neuro ICU. I had to do 2 months or 2 rotations in neurosurgery. I had to do rotations in stroke neurology throughout my residency. And then I had to do, enough neurointervention so that I was coming in as what we call a senior fellow for my 1 year neuroendovascular year, which is the 2nd-year fellow. And so that meant that I had to complete enough diagnostic cerebral angiograms during my residency, and it's 200, so that I was coming in as a single-year fellow. So that is sort of the new pathway. From my understanding, places are starting to try to get it going, but it's really not it's not up and running everywhere. Okay. So we're working on it.
Thank you for that. Just a follow-up question that I had. As you both mentioned several different pathways to A, get exposed to neurointervention throughout your training, and B, actually complete the training to be able to do that in your career as an attending. Was it, or do you think it's difficult, or are there challenges in getting that exposure in the first place, especially when a lot of larger institutions with neurosurgery programs and their own neuro endovascular surgery fellowships have fellows and residents who are also being trained? Was that ground difficult to navigate, or do you think there are challenges that trainees and should anticipate when trying to pursue the different pathways?
Yeah, it was very challenging. I basically did 3 training pathways in 7 years. I had to become diagnostic radiology certified, right? I had to do the IR stuff. And I had to do the neuro stuff. And the neuro stuff is hard because it's a lot of clinical learning that we're not exposed to unless we really, try, right? Like, so 2 months of neuro ICU is good, but it's not anything compared to the neurosurgeons that are my co-fellows, right? Or the stroke neuro, a month on stroke neurology is good training for me, but it's nothing compared to my co-fellow who's a stroke neurologist, and so I was very behind clinically and had to really, really learn, really dedicate a lot of free time into that. A lot of my co-residents had elective time. I never had any elective time. I worked my ass off, to be honest. I think it's doable for everyone, but, it's one thing I will say is that my catheter skills compared to my co-fellows this year were incredible. Okay, so you will be ahead in things and then you will be behind in things for sure. Okay. But the clinical stuff, you really have to spend a lot of extra time learning. It's not something that you're just going to get enough exposure to in this pathway.
Yeah, Daryl, I have to hand it to you. I remember like doing rotations, first year doing rotations of in residency for just diagnostic, and everything's a steep learning curve. You probably had to do that multiple times on different rotations and just feel in that position, and neuro ICU and everything. So it's a pretty awesome training pathway you did, though.
Thank you. Yeah. Yeah. I mean, Um, I think as you guys know, it depends, I think, where you train. And a lot of the jobs that I've that I had offers for this year and stuff, I don't think I would have needed as much clinical knowledge. At Sinai, we manage all of our patients. So even though there's a neuro ICU support, I'm still, rounding on them every day and telling the ICU what I want. And so the clinical stuff is very important. I think at some jobs that I interviewed this year, you would do the intervention and then the neuro ICU completely took over or stroke neurology took over and your sort of clinical involvement was a little bit less important. So I think it depends, but as Dr. V says always, like our clinical education is very, very important. And I think that, I'm very grateful for the clinical knowledge that I have, I think. But I'm still behind. I still very much rely on neuro ICU doctors and stroke doctors and everyone to help me. So yeah.
Great. And then for everyone else, are there any additional fellowships or certifications beyond the residency and fellowship that you completed or had to complete to enter the space, if any at all?
SIR has a stroke course that, some programs, some people who are, some vascular programs, VIR programs who are just body IRs doing stroke. Sometimes they just require you to do that stroke course and get that certification. And it's a really good course. Martin runs it along with some others, and it's really comprehensive. I think they made it 2 days too. So it tends to be at the end of SIR, which kind of sucks because people want to go home. but if you can manage to do it, I would highly recommend it.
I think they've actually moved it to the beginning of SIR
Beginning,
now.
God's beginning. Good.
Yeah. So
I did that course as well. That was a really, really great course. They have a lot of really evidence-based information, and I thought it was really, really, really helpful.
Yeah, highly, highly, highly recommend.
Great. So just want to move on to the kind of day-to-day practice and procedures. The first question is, what does a typical day or week look like for you? And how does your neurointerventional practice fit into this? And I guess kind of what's your split? Are you primarily neurointerventional or kind of a good mix between, as we all know, the broad range of VIR?
well, I can start. Awkward silence.
Yeah.
So our typical day, so the scope of neurointerventions that I did at University of Florida were, diagnostic cerebral angiograms, WADA tests, a stroke, head and neck, um, and traumas, primarily head and neck traumas. And as I've mentioned, I don't know actually if I mentioned this, but we had neurosurgery and also interventional neurology. So they, took care of the aneurysms. So so a typical day would be a blend of body IR, neuro IR, but primarily body IR in my case. And then for call, we took stroke call along with our body IR call the same night.
Yeah, I would say my practice is similar. It's a bunch of body IR guys and two, grandfather neurointerventional guys who do the hemorrhagic stroke, but all of us do ischemic stroke and extracranial interventions. But that's kind of just fit into the day-to-day practice, which is much more higher volume on body IR work. I would say though, MMA embos are becoming really, really, really popular, and they're usually on our board, every day. But they kind of get pushed since they're not emergent, so they'll just add up, and then one day you'll have like 5 or 6 MMA embos.
Are you using glue?
I want to, but we're using particles still. But my two the neuro grandfather guys are like, oh, why use glue, etc. But I like it. We
Yeah.
should. Are you, Daryl?
Yeah, we're using glue. I
It's
love
so
glue.
fast, right? Just like
Yeah, it's the best.
yeah,
Um, I use like, I mean, I train with Aaron Fishman, but I
yeah,
I use that like 8-to-1 now.
yeah, yeah.
And it's really,
This guy from Colorado showed a bunch of MMA cases with glue, and I was like, oh, this is so much faster. But
yeah.
we had some pushback from those guys, and I didn't want to get too much on that.
We can talk later, but we're about to
Yeah.
start a trial with coils, and I'm really not looking forward to it. Okay, sorry, continue.
Just a follow-up question. With the advent of this new kind of training pathway that you were talking about, Dr. Goldman, the one that you completed, and if this were to be something that becomes more popular, how do you, or how does everyone anticipate how this might affect what day-to-day practice would look like as an attending? So if you do go down the kind of this almost accelerated, really dedicated neurointerventional pathway, would that practice look more primarily neurointerventional, kind of joining the neuroendovascular surgeons, or on the neurosurgery side of things, or do you anticipate still to be kind of mixed in with body IR and kind of the typical like VIR breadth? I guess my question is, how does this accelerated new pathway affect the breadth of your practice? or in the future for anyone that completes this pathway?
So I think that's a really good question, and I think it's primarily depends on the job that you're looking for and less on the training pathway, to be honest, because, well, obviously someone who just does a neuroradiology and then neuro IR training is not going to ever do body IR, right? So it does depend on the training, but for me, I had a vast, you know, supply of job opportunity, and they were all very, very different. There's a lot of private practices that wanted me to do body IR and then just stroke. And to me, I felt like I had done way more neuro training than, and I didn't want to, I wanted to do more than stroke from a neuro perspective. I love stroke and I want to do stroke too. I just wanted to do more than that. So and I didn't also want to let go of my body IR skills. Like I love body IR as well. So I think when I was looking for a job, I really wanted something that, was going to keep both of my skill sets up. And most of those jobs were private practice, to be honest, because a lot of if you go into academics, you're paid by one department, for example. And so that department that hires you is either often places it's neurosurgery or, sometimes it's radiology that has neuroendovascular services, but usually it's neurosurgery. And I'm hired currently by neurosurgery now. And then, IR, peripheral IR is under radiology typically. So it's hard to do both. I got really lucky. Again, I obviously am very close with the IR department here, and I wanted to do both. So I'm going to get to do both. But I think if you do this pathway and you want to do both, then most of the jobs that offer that are private practice. And and some private practices are just stroke, and some are all of neurointervention and all of body AR. And there are opportunities. So you have to decide, I guess. And then you can decide, I just want to do neurointervention as well. Um, and yeah, I'm sort of trying hard not to get like right now, my, attending partners, I guess now they're partners, want me to fix all their pseudos. And like I, did an iliac stent on a dissection the other day. Like I don't want to get stuck just doing like, fixing our department's problems. I want to also do body IR stuff that, as well as the neurovascular. So we'll see. And I'm not there yet. I don't know exactly how it's going to look, and I can let you know in, a few years, hopefully. But we'll see.
Yeah, I think a big advantage of doing formal neuro training is something I always wanted, because I participate I participate in aneurysm coilings and hemorrhagic stroke, but I don't do them on my own just because of credentialing with my hospital and just how messy it would be if I'm not formally neuro trained doing those. But I always thought it would be cool to know. I just never had the chance to go back after starting work to do a formal neuro fellowship. So that would be a big advantage of doing, an actual training as well as just learning it better, I'm sure.
I would echo that. I mean, I think a formal training is the way to go, because politically, there's a lot of politics in hospitals. It doesn't matter if you're going into private practice or academics. And the politics in the neurospace, you're dealing with interventional neurology and also like neurosurgery. And it is, without the formal training, it is very easy for them to exclude VIRs from the space.
Hi guys, I figured I'll chime in now.
Perfect. I was excited to hear from you, Dr. Chen.
Hi, sorry I'm late, number one, and I turned off my video because I think my audio is not so great. So hopefully you can hear me. And hi guys to those on the panel. It's nice to meet you. It sounds like you guys are all body IR trained, I guess. And then with additional neuro training, it sounds like. Um, Correct me if I'm wrong.
I think that's correct.
Correct. Okay. Um, I guess I'm a little bit odd one out because I'm not IR trained. I did the diagnostic neuro to neuro IR. And then because of where I was, there was also a year of pediatric neuro IR, which I also did. Um, it's interesting to hear from you guys though, because I feel that way a lot on the IR side. I don't feel comfortable doing IR procedures, even though there's a lot of overlap and, I guess technically you could do them, but again, if you have problems, then you really don't have much of a leg to stand on, and especially in more litigious countries or states, then you have a lot of issues there. Um, so I encounter the same thing on the body side, and I don't do any body IR. I do only neuro IR, and specifically pediatric neuro IR, which is its own beast in itself. I guess I can just mention from the questions in the slide. The typical work week again is a little different because pediatrics is a lot less in ischemic stroke, more hemorrhagic stroke. But overall, the volume is going to be less than what we see in adults. So it's not as high volume as adult practices, and that's why there's generally fewer people involved. I have two others who share call with me, but I think it would easily be shared by two people. In where I trained up in Boston, there was one person who did call for years, decades, which I don't think is recommended, but it just goes to show how the volume of acute middle of the night cases is pretty low. Um, and then because of that, because Texas Children's has a really good vascular anomalies program, a lot of my patients actually are really complex head and neck vascular anomalies. Typically, the high flow ones are the ones kind of um, like certain intracranial shunting lesions require more than one treatment. So unlike adults, we have a lot of like repeat customers. And that would be like uh, AVMs, stage embolization for facial AVMs. And then, of course, on the intracranial side, you have vein of Galen's, PL fistulas, plus minus pre-op AVM embolizations. And then a lot of diagnostic because we have a lot of weird vessels, vascular anomalies or vasculopathies that are not as common in adults. Also, a good proportion are going to be moya moya, so also on the diagnostic.
Yeah.
So,
I would
sorry,
say
long answer.
pediatric neuro IR is a beast. I mean, it's crazy. The cases I've seen are just, I mean, is amazing what you can do.
Oh, that's really kind. But you guys too on the adult side, like the volume, that's my biggest regret, I think, is
Mhm.
that you do feel a little bit like you're not up on the modern stuff, and the literature is like it's that much harder to keep track of because when we started, like right as I was leaving, or the year or so before I left Boston, we were doing dural sinus stenting, we were doing the MMA embos, and since then, like you hear that all the time, and it's like, oh gosh, I have to look it up and to check with other people, like, oh, what's your doing a platelet, and then again, the cases that actually happen are pretty infrequent, and so then there's that extra element of, you know, should I be doing this if I'm not doing it all the time? Even though these are like pediatric cases. So there's a lot of, pluses and minuses, of course. But that's why it's so nice to have, colleagues who are in on either side, adult or pediatrics, and like be able to talk, candidly and describe like, okay, this is what we do. Here are the pitfalls. Having good colleagues is so, so important because, like somebody shared earlier, it's very political. And I didn't realize this, because where I first started my job was where I trained. And so you're protected essentially because the senior people who have trained you are going to vouch for you. But when you go to another institution, you're on your own. And, people, as much as we like to think that, we're here to work together, they will not cut you any slack. So you have to be perfect for years, before people will trust you. And that's hard because, patients are complicated, complications happen. If you have trainees, that, it's another level of unknown. And so, yeah, so having good colleagues that you can talk to, who you can kind of build like a rapport with, is really important as like a junior attending. And it's hard to find that, but it's great when you do. It's great when you can talk to somebody and share ideas, look at pictures together, and do that kind of thing.
Dr.
Um,
Goldman, I was
oh,
wondering.
oh, I was going to suggest one more informal pathway, that's kind of the reverse. And that's what actually one of my partners did is he was neuro IR, trained, and we trained him on everything body. And everything body, I'm talking about peripheral vascular disease, Y90, the whole shebang under, his, formalized job. So everyone talks about body IR learning stroke. Well, he was a neuro IR that learned all the body procedures, and he was very willing to do that. Not many are, but it's really funny. I find him like extremely smart, and when he asks me about like why we do specific things in body IR, I don't have a good answer. So he's just very like almost too smart for us body IR folks. But yeah, that was one kind of other pathway I don't think we really talked about. It's unique to jobs. I know two places in LA who do that, but I don't know how common it is.
Do you have to then take the boards for IR, just for the medical students that might not know?
It's political in the hospital. You just get credentialed. Our credentialing doesn't require you to have IRDR for body IR. So yeah.
Got it.
Dr. Goldman, I was actually wondering, with the emergence of the program you just went through, do you think that there's a possibility for it to branch into pediatric neuro IR from where you came from, or do you think it would have to look completely different?
To do pediatric?
Yeah, would you be able to stem from your training into pediatric? Would it be able to like merge into something like your program for pediatric neuro IR? Do you think that it would have to be an additional some step?
I think, as said before, pediatric neuro-IR as a whole, is definitely something that requires more training, I think, and I would be very, I think, off to say that I could go do neurointervention at this point. Luckily, again, I've been training, Dr. Fifi and Berenstein and Dr. Shigematsu here at Mount Sinai, are very involved in pediatric neurointervention, and I've had the opportunity to work with them a lot during my fellowship. But if I were to formally do pediatric interventions, I would try to dedicate, more time with them, like a full year just doing pediatrics or something like that, I think, or really just work with them in the next, few years of my career to really, get better at that. I think, I definitely wouldn't go do those cases alone now. I think I would feel comfortable, calling Dr. Fifi in for a pediatric case to do with me or something like that. Yeah. So I think that sort of says where I'm at, but I would not do a kid, especially, a baby being a Galen or something by myself right now. No.
Thank you. And then thanks, Rashleen. And we're moving along into the environment and collaboration, which I feel like we've touched upon a little bit here throughout our conversations. So, do you work with neurology, neurosurgery, or other departments when performing neuro cases, and how is that dynamic?
So I am hired by neurosurgery, and I'm an assistant professor in neurology and interventional radiology and neurosurgery. And we work with all of the teams daily. When we're doing a stroke, we're very much involved with the stroke neurologists, discussing and triaging cases and deciding if they're an intervention candidate or not. They help us manage the patients afterwards. Typically, the patients are admitted to us, the proceduralist, initially, and then after a few days, they get downgraded or go to the stroke attendings, who then manage them after that. And neuro ICU, most of my patients are in the neuro ICU, sadly. So I would say I work with them all the time. Yeah.
And then just we kind of touched on this already, but a great question from Austin in the chat, kind of along the same lines. What do you foresee as the future for VIR involvement in neuro-IR, given how much endo work is now done by neurosurgery or neurology, kind of like the same conversations people have about PAD and vascular, but just what are your thoughts on that, and where you see the future?
Oh, I'll chime in there. And I'm interested to see what you guys, other panelists, are experiencing. Because I'm in Houston, and it sounds like Daryl, you're in New York, and Sabeen, you're in Florida.
LA.
You said?
Oh,
Oh,
LA.
you're in. Oh, cool, cool. Okay, okay. Oh, is it Joanna? You were in Florida, or you?
I was in Florida. I'm in North Carolina now, but I was
Oh,
until
nice.
recently in Florida.
Oh, great! Wow, this is like a really nice geographic sampling.
Mhm.
Um, so yeah, it's really interesting because when I was in Boston, even the fellowship, it was only through neurosurgery, and I feel like the reason I even got the fellowship position was a complete fluke, and because it was all neurosurgeons before me, and it was all neurosurgeons after me, and then and so that influences part of the training, because if they're only hiring their own specialties, you're going to be limited in terms of not just the programs but also the experience, because you not only have fewer programs, but you also can imagine at the attending level, like, they're doing less, so you're going to be exposed to less if it's all just siloed in your specialty. And my training was a while ago, and I feel like it hasn't changed that much. I feel like programs that were neurosurgery dominated have stayed as such, and maybe programs that had radiology, either they've split into two programs or they've sort of gone over to neurosurgery. That's also been the case for SNIS. Like, I didn't know this, but our major professional society was actually started by radiologists, and now all the presidents of SNIS are neurosurgeons.
Mhm.
Although Joanna is the president of SNIS this year, so that's different. Um,
No,
so
that's their
what's
me.
that?
Oh, okay, sorry.
Oh, no, no. So I was kind of digressing anyway. Sorry. So so what I've seen is that neurosurgery for the neurointerventional stuff is taking over, because of course they're interested in the highest RVU generating procedures, which are embolizations for aneurysms, and then of course they want to have control over the AVMs because they're going to resect them. And to me, that makes sense, because I don't think endovascular treatment of AVMs is appropriate most of the time. So, it, so it makes sense that they have a lot of um, um, that there's a lot of presence of neurosurgery, but then and then of course, like, as a result, it seemed like to me that neuroradiology and neurology sort of were allowed to be a part of it, but not necessarily, like, the ones who got to decide. And but now I'm seeing that that's changing, at least in Houston. So that's why I'm interested to see what other people are noticing, is that there, because the stroke volume is so high, and traditionally neurosurgery was like, no, 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 we're going to do it all, and now they're like, no, we can't do it all. So in a hospital nearby where I am, they actually have more neurologists involved because they just don't want to deal with the stroke volume, which I think is very interesting. But then, of course, it all depends on how it gets played out. Like, who can say, um, basically, it's a question of leverage, in terms of leveraging what they want with what you want.
Yeah, I would say in LA, what I've seen is definitely a high presence of neurosurgery, trying to own stroke, take over a lot of programs that have stroke. But I have seen where, yeah, the volume's getting high, but it much easier goes to neurology. And we just have very little neuro IR here, that it more easily goes to neurology than someone who is VIR and can, willing to learn or already knows stroke. That's just politically from what I know from a couple hospitals around here. And then I was mentioning in the chat, it's just hard to hire, some of these groups, these private groups out here, we need people to do both body and neuro. And even if someone's dual trained, I've actually seen a lot of dual trained people who say that they don't want to do body, they just want to do neuro. Um, and so it's crazy. Yeah, that's what I've seen in LA.
Mm. Yeah, what I've noticed for neuro IR is, uh, again, like in Houston, I think it's hard to find a job that, um, if you're interested in research or if you're interested in a sort of wide ranging practice, because there's so many neurointerventionists here and a lot of them are quite senior. So the competition's pretty fierce. Um, so we wouldn't have a situation where somebody's like would do body and do neuro, because like everyone who does neuro only does neuro, and even then like there's a lot of fighting amongst them. And I mean, that's actually a big reason why I went into the pediatric neuro IR, because I thought I could avoid some of that politics, but that was really stupid. You can't avoid politics, period. I avoided maybe a certain segment of the politics. Um, but uh, yeah, I think at least in big cities, and this was my thought in Boston too, and I mean, you guys please chime in, is if you want to have a pure neurologist job in a big city, it can be really hard, or you have to kind of run the risk of either not being that busy or doing a lot of cases that maybe you're not interested in doing, or maybe are not great on your lifestyle, like a lot of stroke. Um, and most neurointerventionalists, I think, they will tolerate a certain amount of stroke, but what they really want to do is build their practice for like the really cool sexy cases like flow diversion and stent assisted coiling and web and weird things that involve new technology, maybe dural sinus stenting if they can tolerate the patient population. um, and the newer stuff, which is fun, like MMA embos, because you can kind of treat these patients and then there's like a kind of quick sort of turnaround. um, and I mean, I think what it comes down to is like being well, I think in terms of hospitals, like being a adequate RVU generator, and that's what ultimately gives you that bargaining power if you're getting hired. And if you're saying like dealing with colleagues who are like, oh, you're not doing enough, like it comes down to, okay, well, I've already generated this many RVUs, and so that's where all of the motivation comes from. Like if you have those high RVU generating cases like ruptured aneurysms, then you sort of establish your presence and you can whatever justify your income and your position. um so like, I'm sorry this got like super technical, but that's kind of the world that Houston is. I mean, other cities, hopefully it's not the same. I'm sure it's that way in New York, and I'm sure it's that way in Boston. um and so a lot of this stuff unfortunately is, it's like if you have the appetite to understand and to kind of like play that game, and if you don't, that's totally okay, because I do not like playing that game. But a lot of a lot of it comes down to, again, having colleagues who support you, support what you do, see the value in what you're doing, your mission. Not everyone wants to just, generate a ton of reviews, make a lot of money, and be able to brag about cool cases. Like it is, it really is. For me, it's about the patients, and having a connection with them and seeing that there's a real need, for someone who is thoughtful, is conscientious. Um, and so, there's a wide extreme, I think, in motivations when you get out. Like you'll see that. And I think it's just finding the right fit, amongst your colleagues and, your administration.
Dr. Goldman, Dr. Kee-Sampson, do you have anything to add to that from your regions? And I know, Dr. Kee-Sampson, you had just recently transitioned, so do you want to speak maybe about the differences that you anticipate?
Yeah, I mean, politics, you can't avoid them. Even for formally trained neuro IR is like, it depends, like Dr. Chen says, it really depends, well, what department are you with and which department is the strongest at, locally at the hospital. You can't avoid that. And that actually ties into, where I was at University of Florida. The so a little bit of background, like VIR started the stroke program there. Probably it was before my time there, but it was like probably 15 years ago, started the stroke program and helped the hospital become a comprehensive stroke center. Fast forward, until about, I would say about 3 years ago, where um, neurology really amped up their faculty hiring, and then they hired, many vascular neurologists along with interventional neurologists. The neurosurgery also kind of amped up their hiring, and then once they got those people in place, they really started really, strutted their political power and pushed VIR out of the neuro IR space, pretty much. So, you know, you can't avoid politics. And and sometimes that kind of comes down to, just sometimes it's actually beyond the individual. A lot of times it's beyond the individual physicians, right? It comes down to the leadership of your individual departments and the leadership of the hospital system and which department's a favorite child during that era. So I would say that at the very least, if you're interested in doing neuro IR, pursue one of those formal CAST approved pathways. I really do think that that protects you to a little bit, to a certain point, where that's one less excuse for you to be pushed out of that space. Um, and then, the rest of the politics, well, all politics are local, really just depends like where you end up. And it changes too. It's local and changes just like at University of Florida, it was VIR dominant, doing a lot of neurointerventions, and then all of a sudden it wasn't, so.
That makes a lot of sense. Just another question kind of along the same lines. And we have a bullet on this slide about work-life balance and neurointervention. Does anyone feel like, because now Dr. Chen is mentioning kind of offloading of the stroke work and not everyone wants to do it. Do you think that when it comes to neurosurgery and stroke call and the stroke workload, do you think that workload is often disproportionately offloaded onto the IRs that are trained in neurointervention, and how does that affect lifestyle, if that's the case at all? And just kind of like what are your experiences when it comes to kind of the distribution of workload and the stroke work?
I'll start with that. I think it again depends on the job and the place, but yes, I think definitely, there are places where primarily endovascular neurosurgeons want someone who can do stroke, but not do aneurysms and take their aneurysm volume, for example. And then they really want help just covering stroke call, for example. And so one might say, yes, that's offloading some of the stroke, right? And those people are valuable to them because they don't necessarily want to share the aneurysm volume. Um, and there's a ton of stroke volume. I think it depends on, and that's something really you want to look for in a job. If you want to do stroke, and then body, for example, if that's something you want to do, that's, more power to you, but just understand that, you're being, put into that sort of box, for help with stroke call only. Um, and that makes you very valuable to them and you will get paid very well. So some people, that's good for them, and it's okay to be that person. It's just you have to understand, I think, what's happening. And then there are other places that you're like, for me, I'm hired by neurosurgery right now, and we split the call equally with the neurosurgeons, and I consider myself pretty lucky because my neurosurgery partners are, when they're on call, they're doing strokes and also open call hemicranies and stuff like that. Typically, they're covering both, so my call is usually better, to be honest. Um, yeah, so it just really depends on the job.
Are you covering any body IR call too?
I'm credentialed in body,
Yeah.
and I'd like to cover body call. I think we're sort of working that out still. I'm doing body interventions, but not, but yeah, we're trying to figure out the call stuff. I don't think that they really need that much help with call, but I want to.
Yeah.
Yeah. And then, and it's, again, I think it's very new for everybody at Sinai too. So we're trying to navigate that. Yeah.
Dr. Goldman, might be a little bit of an aside, but just something that popped up into my head. When you were doing your kind of dedicated neuro IR years, are they true like dedicated neuro IR years towards the very end, or are you also kind of dabbling in the body IR at the same time?
The, the last year is all neuro IR.
Okay.
And then I did 3 months at the end of my IR fellowship. I did 3 months leading into this full year, also dedicated neurointervention.
Got it. Thanks.
One
And so, oop,
one question I had for Dr. Goldman, because I think the pathway at Sinai is, a great opportunity and hopefully it's more integrated, but for all those who graduate from just the standard VIR residency where they don't do extra neuro, what are your thoughts on maybe like a 2-year fellowship where instead of doing, diagnostic neuroradiology certification, you're spending more time learning like the, neuro ICU, neurology, um, and give that as option for people who really just want to do the interventional part.
Yeah, I really think that that's a great idea. I think if people haven't done those like prereqs that I did throughout my residency, it would be a really great thing if we could offer IR integrated residents 2 years of neuroendovascular so that they're not going back and doing neuroradiology fellowship after doing, interventions for 6 years or whatever, but that they're actually coming in for 2 years instead of one like I did, and maybe the first year is very clinical, with a little bit like with more clinical ICU time, stuff like that, and some neuroradiology time too, maybe. And then the last year is all endovascular. I think that would be really, really great. And I think that's what I was, speaking to Dr. Kee-Sampson about initially when we first logged on, was that we sort of have a variability in the exposure to catheter work, endovascular work that the new fellows have when they're coming here. So even these neurosurgeons that were supposed to have done or logged, they did do an infolded full year of endovascular, are coming in and it seems like they've never, used a catheter before. And so for those people as well, we might be transitioning at Sinai to 2 years. Everybody has to do 2 years when they come here. And so I think in my experience, if we could cut out the neuroradiology fellowship for people from my background, I think that would be great. I would have done a 2-year fellowship. I mean, I think the neuroradiology fellowship is difficult to palate after doing, an IR, fully clinical IR and, procedural residency. But I also think that the people that have done formal neuroradiology training are so, educated and incredible. They have this incredible skill set too that I don't have. So it's hard to say.
You mean you don't want to read fMRIs and crazy
No,
head and neck cancer imaging?
I never want to be a diagnostic radiologist, but I will say that like they have more the neuroimaging is so important in my everyday work. And so, and I think from doing an endovascular fellowship, I've seen more neuroimaging than a lot of diagnostic radiologists. So I feel very comfortable with neuroimaging, because of that. But it's just important to also make sure you're becoming educated in neuroradiology for this job.
I agree. I think 2 years for neuro IR, I mean, dedicated 2 years, because I've also seen enfolded fellows that don't do much at all. They're maybe like secondary scrub, but they're not, actually doing the cases, the diagnostic cases. So um I guess it just depends. I feel like so many people have different exposures and levels of like confidence. But a dedicated year in just learning the skill, building, because then you would build on that, right? And a lot of, I think the 2 years too is really just gaining that volume. So if you're at a super high volume center and you see a lot of um, weird things, then you probably would be okay. But I think those are becoming fewer and fewer. And so, seeing how different aneurysms can be, can present, how they can be coiled. Um, and then, of course, like other like shunting lesions. I think it's just getting the breadth of that experience in a year is tough. And, like uh, Dr. Goldman was saying, a lot of enfolded years are not really, they're not equivalent to a year of like dedicated endovascular, neuroendovascular training. um, and just the handful that I've seen, it's kind of strange to me that some people feel okay after a year. When I think maybe even if it's cast accredited, I think it does come down to the judgment of the person and the judgment of those who are treating them. I also want to comment on the neuroradiology thing. I didn't know that that was no longer a requirement for the fellowship, or to be like NeurIR, I guess, certified. Um, I think maybe just a thought, like politically, and also in terms of, like, your contribution to the group, because imagine you're going to be in conversations with stroke neurology, or interventional neurology, and then of course like cerebrovascular neurosurgery. I always felt that um, having a handle on the radiology, and I think you will regardless, but I think for me, that extra year just gave me that confidence to look at those images and I guess in a way contribute to the field more than, like that's your comparative advantage essentially. Like neurosurgery and neurology are not going to be able to look at images the way you do, and that's the same for angio. Like you can read an angiogram better than them, but it comes down to just honing that skill. And I mean, you can for sure do that during residency, for sure do that during fellowship, but I did feel that year was like super valuable in that regard.
Yeah, I can imagine. And I've heard that a lot, from people that because of the, diversity of the field in terms of backgrounds with neurology and neurosurgery. The one thing that we really have that they don't is a really strong formal education in neuroradiology. So, and I don't have that.
But it
This has
sounds
been a
like
really interesting conversation. I wanted to move along just because, in the interest of time, and also because this is a lot of what I think students that are at my stage are here for. I'm like an MS1, so I'm just starting out. And like Dr. Goldman, what brought me to NeuroIR, even to begin with, was my interest in stroke. And so I just wanted to put this out there. What would you recommend for students who are interested in this field right now, or even residents who are interested in opportunities of adding neurointervention into their VIR pathway? And I'm going to loop in the second question too. If there's any resources, rotations, or mentors that were particularly valuable to you, please like speak upon those as well.
I think I'll chime in a little bit here again. I'll put a little shout out for the stroke conference. I know that's focused on stroke, and not all neurointerventions, and so I'd parlay that to I mean these conferences like SVNS and all these conferences you can maybe go check out. It'll be at maybe a kind of high level for an early trainee, but I think it's worth checking out. And the on social media, there used to be a lot more, but there was a lot of neurointervention talk and cases posted, and you could kind of see. And on I'm trying. I haven't done as good of a job, but I'm trying to increase the neurointervention category at Backtable. So we would have some topics coming up.
Yeah, and we want to bring more cases to this space as well. I think moving forward, Ashley and I had spoken about featuring case studies moving forward. So we're hoping to have that here at WCBS.
I think, the same things like, I used to say for body AR, just really get involved with your societies. Things like WCCVS is great, get involved with research, come to the departments and try to do some research and shadow all of that. And yeah, I think that those are my recommendations if you're really interested in that stuff. And then there's just so many great, education tools and stuff going on as well, like Backtable. There's various, webinars through SNIS and SAR, all of that stuff. So I would just really join those societies and try to get involved and listen to that stuff.
Great. And then I think one last question before we wrap things up, especially the medical students who are looking to apply again, like I'm a fourth year applying in the upcoming cycle and we're evaluating programs. A lot of us are realizing that, we're very undifferentiated right now. And so we obviously don't have very set interests, but still want to be able to have the opportunity to be exposed to neurointervention, and even things like vascular and other things that are often owned by other services. But do you have any advice, or is it possible, regardless of the program that we might end up in, that if we advocate for ourselves, these are elective time well, are there ways to get exposed to neurointervention at programs that might not necessarily have formal neurointervention program or training? Because I know every program is different. So I guess that's my own question.
I think you guys are like ahead of the game. I didn't even know that neurointervention existed until, after basically my intern year. No, after I had matched into radiology. So, that's a whole other story. But, I think if like all the things that are going on in the chat, those resources are great. The meetings are awesome, especially if you're interested in stroke. Yeah, like ISC and SFIN are really good. Um, if you're interested specifically in stroke, then you have to have an appetite for a lot of data and knowing the literature, which is awesome. I mean, that's such a great skill. And I think specifically neuro-IR, I think just maybe first figure out, like, is this something you enjoy? Like, yeah, it's intellectually stimulating, but it's super stressful. Like, is this like what you want in your life? I mean, it's really hard to say because you guys are what, in your late 20s, and I'm like in my geesh, like almost mid 40s, and it's very stressful sometimes, and I just think, do I really want to live like this? Um and thankfully I have like a lot of vascular anomalies which are like relatively low stress, but you know what you want in your 20s is really different from what you want in your 40s and probably in your 50s and 60s. I don't know, when I get there I can tell you, but again, it's also a lifestyle question. um and when I talk about the stress, it's not just the case, it's also the stress of dealing with partners or colleagues who maybe you're not going to support you. Like, if something bad happens, you could very well get thrown under the bus. And I've had colleagues share with me, like, oh, this happened, and they don't talk to their partners because of that very reason. It's just there, it's a minefield out there. And that's why, again, I'm saying it matters so much, like your immediate colleagues, like thankfully, like my fellow IR guys at Texas Children's. And that's why I love IRs, because they are the best. They've gotten me through so much, like, hard times. My husband too has been super supportive. I think it's super interesting. You can have such a huge impact on patients. There's all kinds of awesome research to be done, but again, just keep in mind, like, it can be very stressful. And um, like, eh, of course, you can always off ramp, right, into diagnostic, off ramp into locums, or do something where you're not in every day just face to face with these kinds of situations. But yeah, just get exposed to it, see the cases, see how those attendings are dealing with that stress in their life, how they balance it. And if you're still game, then yeah, do all the things like research and getting to know your colleagues or the attendings who do that. Try to find a program that has that. I mean, it's not a question of if you'll get there. You will. You'll definitely get what you want. It's just, is it really what you want? That's the real question.
Yeah, I mean, I'll say I'll kind of second that what Karen just said is, yeah, you have a lot of energy in the beginning, so now I just turned 40 and I have kids, and the stroke stuff gets tiring. I still love it, but I can, you want to just make sure you have everything. I think having the skill set and then determining what you want later is always then you have it, or if you have that formalized training, then you can, define your pathway a little bit more depending upon what interests you. But yeah, yeah, I am so grateful to have had a group that taught me stroke, and I can, as Joji was saying, is you use all these skill sets and use it in body, and yeah, that's just I know that's not available everywhere, and I'm grateful for having that.
Great. Thank you so much to everyone that joined. We just want to take a second to thank you all. I know everyone's really busy, and we're so grateful that you made the time to come and speak with us. These are pearls that we truly would not have gotten anywhere else. I know it's very difficult to be exposed to VIR in general as a medical student. Forget neurointervention. So we're so happy that you were able to join us on our first panel. We will continue to be having neurointervention panels as part of our series. So looking forward to everyone joining again. Thank you to our other participants in the chat, and everyone that was able to join us from around the world to be able to listen in. So thank you so much, and really appreciate your time. Thanks for a great session.